So, update on obesity. There's a lot of new stuff happening here. During my career, obesity has changed from, don't you know this is self-induced disease, to a complex, chronic medical condition, and it's now getting almost the same dignity as hypertension, which is an analogous chronic medical condition. So I've divided the slides into two parts here. Some of these slides are conceptualization slides, and I'll spend a little more time on them, and some of them just present facts. And the slide deck has some hide slides in it that goes into more depth. Okay, so what we'd like to deal with here would be something about the physiology. What's really going on with this condition? And then we'll just switch from there to treatments. And the treatments, or the tools in the toolbox, are quite minimal. We've got 3, and only 3. One is lifestyle modification with respect to diet and exercise. 2 would be drugs, and we're now getting some that work and that are safe. Terrible history here. Whole lot of bad drugs. And so one of the things we have to do with our patients is convince them that, well, maybe these are a bit safer. And then surgery. And finally, we've got access to good bariatric surgery. At the Ottawa Hospital, there's been 5,000. And the safety rate on bariatric surgery is extremely good. So with that in mind, let's go on. Now, this slide is defective. What it's supposed to show is the seesaw, energy in versus energy out. That part of the seesaw didn't come across on this slide, so sorry about that. But the seesaw is affected by biology. So what are the factors that affect energy input, and what are the factors that affect energy expenditure? And we'll spend a moment on that, because most of the papers dealing with energy output in the last 2 decades come from this institution. And these are the other things that affect. So it's not just our genes, it's our society. Parents are having concerns about safety of their children, so they get driven to school instead of walking to school. There's incredible pressure to eat high-fat foods in our society, and it goes on and on and on. So obesity is a chronic medical condition in a biopsychosocial model. It's a complex genetic condition interacting with complex societal factors. There are hundreds of loci on the human gene map, well over 200, and probably as many as 600, that have something to do with energy intake or energy expenditure. Genetic aspects were long suspected. If you read Osler's textbook, even in the first edition, he talks about the familial aspects of obesity. And so a lot of work was spent looking on point mutations. And in pediatric populations, point mutations may be as much as 4%, and that's it. And in adult populations, it's much less. And so what we now talk about would be gene loads. You have these regions on the human gene map, hundreds of them, and alleles can go in there that are more conducive to weight gain. Some alleles fit in the same place and they're more conducive to weight loss or weight maintenance. And you add them all up, and if you've got a whole bunch of them all lined up to encourage weight gain, then we say you have a high gene load. So that's an important concept. But the other thing that comes out of this is the incredible heterogeneity of obesity. This is not one disease, it's the obesities. And this comes across in so many ways. You see some diets working for some people and not working for others, and when you mean them all together, you find the diets are so-so. The same with drugs, the same with surgery. And so one of the things we have to be wary of is that this is a very heterogeneous group of diseases, and one day we'll be able to triage them into the appropriate treatments, and now we have to do it by trial and error. So we think of different treatments for different folks. That's a conceptualization slide, so that's why we spent a bit more time on this. So if we look at our biology, and unfortunately the first seesaw is missing, up at the top should be energy intake. So those are things that control food intake. And about 60% of the gene loads and the point mutations have to do with energy intake. But we now understand there's some that have to do with energy expenditure. And we had a wonderful experience with a collaboration that's gone on for 2 decades with Ruth McPherson and Mary Ellen Harper that looks at energy expenditure, and there are about 30 publications in this, and we know some of the genes now that are involved. And we can pick these people out. We first of all had to pick them out by their response on a very standardized meal replacement, and now we can do it by proteomics, gene expression products, and whole blood, and now we actually know at least one of the candidate genes. So this is weight loss is a heritable trait, ability to lose weight. We've seen it in the behavioral therapies, which came from here, and that from Harvard, which looks at heterogeneous response with bariatric surgery. So let's consider it then and compare it with hypertension. Obesity and hyperadiposity are analogous conditions. And I'd like to put in a plug for hyperadiposity because it's totally non-judgmental, just like hypertension is. Obesity is considered a bad word, fat is bad. Morbid obesity is terrible. So we already have patients who are really abused by this thin-oriented society, so maybe we should have better names, and hyperadiposity works well. So one of the things you have to remember about hypertension is that it's the treatments only work while you take them, and that's exactly the same way with obesity. And what does success look like? This is a very important point. Again, we're talking about conceptualization of things. So everybody knows about weight loss, but what most people don't know about would be this part here. Whoops. So when you lose weight, you reach a new plateau, and when the patient's in that plateau, they're not continuing to lose weight, and they think the treatment isn't working. So there has to be counseling to know that, okay, they're at a plateau now, but that plateau is a number of pounds below the initial plateau. Then we go on to where do the treatments fit? Another conceptualization slide. This comes from the Canadian Clinical Practice Guidelines. And here we go. Lifestyle modification is the bottom of the pyramid. We're not saying that patients are overweight because their lifestyle is bad. When you actually look at it, it's about the same as everybody else. But with their genetic makeup, it's too much for them. And so we always have to caution patients and say, look, we're asking you to make lifestyle changes, but those lifestyle changes have to be better than average, because with your genetic makeup, you have to have more powerful behaviors to keep them in check. And the same with physical activity, so diet and physical activity. Then we go up here to pharmacotherapy. That's indicated for BMI 30 or 27 with comorbidities, and then surgery is body mass index of 35 if you have the really bad comorbidities like diabetes, and body mass index of 40 if you just have weight. So that's just how the treatments fit in. So setting the stage for treatment or hyperadiposity, understanding what success looks like. So we already talked about the plateau, and patients have to be counseled about that. But there's also, the Metropolitan Life Insurance did a terrible thing for us. And that is they published the ideal body weight tables in 1948 to talk about insurability. And we assumed that that should be the goal for weight management. And that was a terrible, terrible assumption. If you have a person who weighs 400 pounds and their ideal body weight is 120, thinking of getting to that would be outrageous. Certainly as people go up with their body fat, they go up with their muscle mass, they go up with their bone mass, and so they're now overweight because of all these three things. And what we're trying to do is get people to bring their weight down 5 to maybe 15%, and we're trying to get them metabolically normal but still overweight. And that's as much as we can do now, even with the very powerful techniques like surgery. So teaching a patient what success looks like is key, because if they don't get to what they feel to be successful, they don't keep it off. So they might say, I want to get to the ideal body weight tables. That might be 35 or 40% weight loss, and we're talking about 5 to 15%, so coaching has to be done there. And then the understanding that obesity is a chronic medical condition. How many patients do you have coming to you saying, you know, doc, I know if I can just keep it off, if I can just get it off, I can keep it off. Well, that's the worst statement possible, because there's a really considerable effort that has to go into keeping weight off. Okay, so let's now go to the diets. So now we're getting into some of the treatments, and here's a zoo. Remember the heterogeneity of obesity. It is preposterous to think that one diet is going to work for everybody. So basically, in some people, they all work. So probably the best studied is the Mediterranean diet. We officially strongly encourage that. Low-carb diets, and here what you're doing is you're replacing carbohydrates with proteins or with slowly absorbed carbohydrates. The latter would be the South Beach diet, the former might be Atkins. And now we've got something new on the block. It's called ketogenic diets. These are diets where people replace the carbohydrate with fats. Now, there's some really airy-fairy thinking about this with no evidence whatever. And one of the things we have to recommend to our patients is they forget the coconut oil, which is a saturated fat, and really raises LDLs, and yet we have people actually drinking it. Sure, it raises the ketones, but it does not. It's not healthy. And the other thing is there are people selling packets of beta-hydroxybutyrate, which is a ketone, and there's no evidence whatever that this works, and it's $5 a throw, and you're supposed to have one with each meal. So you have to protect your patients. But by and large, ketogenic diets have something in common, and the Division of Endocrinology is encouraging that for especially the people with type 2 diabetes or insulin resistance. So now what about the drugs? Here are the drugs that are available. Orlistat has been around. The thing with Orlistat is you have to make very sure patients are already following a diet. If they're just doing Orlistat alone, they may gain weight with it. Lorcaserin's available in the US and has been for about 5 years. It's not available here. And phentermine and topiramate have been available in the US for quite a while, and it's actually a very powerful combination, but it's not available here. Neither can we get phentermine here. It's off the drug list. But we do have Liraglutide, which was the first one, and the reassurance of safety here is that it was used in diabetics for a good 6 years before it became used as an anti-diabetic drug, as an anti-obesity drug, and so it has a pretty good safety record. And we always have to try to convince our patients about the safety of these drugs because of the bad track record that we've talked about. And naltrexone and bupropion is now the new kid on the block. It's been available here for about 6 months, and it's been available in the US for about 6 years. And it's a combination of 2 drugs we've had for 3 decades. One is naltrexone, which you will likely talk about, and the other is bupropion, which is an antidepressant that's been around for 3 decades. Now, the other thing we want to, again, a conceptualization slide, and this has to do with the heterogeneity of response. So the beige line is the placebo, and this is liraglutide. But you could do the same thing for Contrave. And so now, when you look here, so these are the number of people who did not gain weight on the intervention. So 65% of placebo didn't gain weight with the intervention, and 92% of liraglutide didn't gain weight. So they were at 0 or really good response, so the whole spectrum. Now let's go on to the next one. So the next one looks at how many got 5% weight loss. And so you see 27% of placebo got 5% or more, and a full 63% of liraglutide gets 5% or more. Now look at this. Now you're getting 10%. So placebo, even so, and placebo, remember, is not just, it's a behavioral program, the same behavioral program that the drug group gets, but the patients don't have drug augmentation. So placebo, only 11% get 10% or more weight loss, but 33% of liraglutide do. And when you get down to here, you're seeing 14% are getting more than 15%. But when you look at it from a mean, you see the means are, there's a previous slide showing the means, and the means are down around 5% difference. But you see that a significant percentage of these people have a really good response. So just some catch-up things. Reassurance the drug was originally approved for persons with type 2 diabetes. Liraglutide has a whole bunch of actions. Probably the effect on weight is central. And liraglutide is a GLP-1 agonist. When the bariatric surgery is done, GLP-1 is released from the intestine in huge amounts. But it has a half-life of seconds or maybe a minute at the most. So this was stabilized. It happened to be stabilized with a lipid part to trammel up the aminopeptidases and carboxypeptidases in the blood. It has the half-life of 13 hours, but that lipid moiety can take it centrally, and that's where it works for weight. It also reduces the insulin resistance peripherally and so on. So an interesting drug. If you take a look at the means, this is what you're seeing. You're seeing placebo up here, and you're seeing liraglutide down here. But whenever you interpret the means, remember the heterogeneity of response. You're seeing changes in comorbidities with it. Remember, it was originally used as a drug for type 2 diabetes. And you see a very good decrease of A1C by about 1%, even if they're on a whole slew of other drugs. Changes in lipid profile, decrease in total cholesterol, marked decrease in triglycerides, increase in HDL. Changes in blood pressure goes down, both systolic and diastolic, but the pulse goes up. And we don't know a lot about that. So what about you guys who are dealing with paroxysmal atrial tachycardia? What effect might this have on it? And that's an unanswered question. Safety overview. Nausea is the biggest thing. Non-dose dependent increases in heart rate, we just talked about. Gallbladder disorders, that seems to be from the weight loss. With first of all, obese people are more likely to get gallbladder disease, cholelithiasis, inflammation, and when they lose weight, they're more likely, and it seems to be just the ones who have a good weight loss. Acute pancreatitis, this is not, in the original studies it showed a small percentage. That's not been borne out with subsequent studies. So pancreatitis seems to be even further down on the list. And then malignancies, no increase in malignancies overall. Remember, we've been looking at our own data, and we see now that the biggest killer for obese patients is not cardiovascular disease, it's cancers. But there is, in one of the studies, a finding of one or two more women with breast cancer in the drug side than in the placebo side. And it's not statistically significant. The regulatory bodies haven't commented on it, but I personally want to make very sure that that woman, especially that woman who's fighting breast cancer, knows about that. And then she decides. And you know, it's a bit of a hard decision because we know that having the high weight is associated with cancers. So it might be the losing the weight is actually helping things, but the studies aren't long enough to be able to tell us that. Okay, now there is something about prescribing this drug and Contraid, and that is the insurers like to see success. So they like to see a 5% weight loss or better in the first 3 months. However, what we do is we use it a lot for helping people keep weight off once they've lost it. And there, that requires a special letter to the insurer. Now let's go on to the other one, the bupropion and naltrexone combination. It again works centrally. There are slides in there that can help you with that. And so I'll leave that as it is, but it does work centrally on the pro-opiomelanocortin system. So, and it reduces appetite and gives people better control over food intake. So we already said that bupropion has been in use for 30 years as an antidepressant. It's also used for smoking cessation in the form of Zyban. It's the same drug made by the same company, and now we have it to deal with weight. But what, again, a part that hasn't been studied, but what I would like to question, and that is, what about that overweight person, the hyperadipose person who's smoking? This might be a drug of choice for it, okay? The doses aren't quite as high as it is for Zyban, so it's 360 a day instead of, I don't know, 400 or something. So it still should work. So just think on that. No evidence for it, but just question it, okay? And naltrexone has been around, a powerful opioid antagonist, and that's been used to treat alcohol addiction and relapse to opioid addiction. But the other thing it does is it makes it so that drugs that contain opioids for pain management won't work anymore. So you've got to bear that one in mind. Weight loss efficacy. There's another slide that's hidden in there that shows if you use it in combination with a behavioral program, it works a lot better. So what are the secondary endpoints? It does reduce the hemoglobin A1C, but it is not indicated for type 2 diabetes treatment, but it does reduce A1C. Changes in lipid profiles, increase in HDL, mild decrease in LDL, decrease in triglycerides, not quite as good as liraglutide, but there have been no head-to-head trials either. And changes in blood pressure. Minimal effect on blood pressure. Blood pressure stays same as baseline, tends to run a little higher than placebo though. But the placebos reduced blood pressure more. These didn't reduce it as much, but again, you have the pulse rate of 2 to 3 per minute increase. Dosage considerations, you start gradually and work up. You do it with both of the drugs. Those are formulas, and we won't spend time on that. But what about the adverse events? Well, nausea is big here too. Constipation, also. Both drugs doing the same thing. Headache, a little more common. Vomiting is there. Dizziness is there. More than placebo. Insomnia, dry mouth, diarrhea. So the side effects are there. The actually side effect profile looks roughly the same for both drugs. Contraindications, let's spend a moment on that. So the contraindications are for both drugs separately. Chronic opioid use and abrupt discontinuation of drug use. Bupropion, uncontrolled hypertension is a contraindication. Bupropion containing drugs, let's not use it with Zyban. And seizures, bulimia, anorexia nervosa. Abrupt discontinuation of significant alcohol use that lowers, and this lowers seizure threshold a bit, and so on down the list. So, roles for medications, use with diet and exercise, that's straightforward. The insurer is likely to do it if you get 5%. Use it post-weight loss when patients have been on very low-calorie diets or low-calorie diets. And amazingly enough, Liraglutide works in post-bariatric surgery patients. You know, usually I was thinking, well, there's a huge amount being released post-bariatric surgery. And, you know, now that we've had experience 5 and 10 years down the line, we're seeing weight regain after bariatric surgery. And of course, we want to make sure that it isn't anatomical failure that has a surgical treatment. But most of them are not, and this drug seems to work pretty well in that scenario. Now, just a word about behavioral programs, and this is the second use. How's my time? I got a moment. So behavioral programs result in good weight loss. So initially, immediately after the program, you're getting as much as 29.7% weight loss. If you look at it 5 and 7 years down the line, you're seeing some weight regain. And so still you're seeing effectiveness because it's what the guidelines say. Most of them are keeping off, or many of them are keeping off 5% weight. But one of the really good things is that these drugs can be used to help improve weight regain. Now, the surgeries we'll just spend a moment on. Laparoscopic adjustable gastric band is not covered by OHIP. There's a reason for that, and that's 50% of them have to come out within 2 years. And they advertise that it's the lowest risk procedure, but if you think the way Bob Dent does, you think it's the highest risk procedure because 50% of them have to come out in 2 years, and the surgery to remove it has a significant risk. And then you've got to do something proper, and now it's really risky because you've messed up the stomach. So this one is, there might be a place for it, and that is the patient that's very high risk that you guys are dealing with. And maybe slimming it in, getting them to lose a bit of weight, and then doing a definitive procedure afterwards. But that would be the most that I could see for it. The gastric sleeve is gaining credibility. It's just you remove the greater curvature of the stomach, and you're making the stomach into a tube. And what you're doing is actually removing the cells that produce a hormone called ghrelin that makes us hungry, that makes us resistant to insulin, and that's obviously one of the ways that it works. The Roux-en-Y gastric bypass is the gold standard. You make the top of the stomach into a new one, you join it up to the small intestine about 1/3 of the way down, you're reducing absorptive surface. You are reducing the amount that people can eat, but when you're dumping undigested food into the distal third of the small intestine, you're releasing this huge amount of GLP-1, and that's thought to be a very major way that this works. The duodenal switch is the most powerful, but it has the highest mortality rate. Now, gastric sleeve, Roux-en-Y gastric bypass, and duodenal switch are essentially surgical cures for type 2 diabetes. The diabetes goes away within hours of the surgery. The most powerful one there is duodenal switch. You get a 90-odd% amelioration of type 2 diabetes. The Roux-en-Y is still pretty good at 85%, so just bear that in mind. The schematic of the surgeries and some tips about referral. It used to be you could refer to the weight management clinic here. The problem is that it's now essentially a generic clinic. It's part of the Ontario Bariatric Network. It has the same protocols and all the same rules that Sault Ste. Marie has. It probably shouldn't be in a tertiary care hospital. But both Dr. Shao and I were very disappointed by that. And Judy took the initiative to start a clinic on the outside, which is working really, really well and has a very strong connection with the Department of Medicine. It's Leaf Weight Management Clinic, and if you have that kind of patient where you're not sure whether it should be a medical program or surgical program, you can always refer them there, get a good consultation, and if bariatric surgery is indicated, they will refer right to the OBN, save you the trouble. So a Leaf Weight Management Clinic has been a great, I've been very delighted with it. So that's a few tips, practical things, conceptual things. And fortunately, that's all I have to say because we're 1 minute over time.